Good morning, everyone. Today, I'm going to present on a condition that every one of us face in our day-to-day practice, that is atrial fibrillation. Atrial fibrillation happens to be the commonest sustained arrhythmia, which is clinically significant arrhythmia that we face in our day-to-day practice. It affects a large segment of the population globally. In 2020, about 50 million people were estimated to be suffering from atrial fibrillation. And this is a rough estimate. Large number of people also remain undiagnosed. So actual number may be large, maybe more than what is quoted. In the United States in 2015, about 5.6 million people were diagnosed to be suffering from atrial fibrillation. And they found that back calculation wise, they found that about 11% would be estimated to be undiagnosed. Although the diagnostic modalities and diagnostic reach have improved, but still we know that large segment of people remain undiagnosed. So the actual number will be large. Atrial fibrillation is a disease of aging. So as the age advances, the actual number, the population number is going to increase. As per the one estimate, the number of people suffering from atrial fibrillation is going to double from what it was in 2010. So from 2010 to 2030, it is going to double. Overall lifetime risk in an adult population is 30 to 40% in white individuals, 20% in African Americans, and 15% in Asian population. So everybody who's present in this house or watching me has about 30% lifetime risk of suffering from atrial fibrillation. We may or may not, but that is the risk we carry. We know that atrial fibrillation is associated with thromboembolic events, especially stroke, which it increases by 2.4-fold. But there is a host of other complications caused by atrial fibrillation. Atrial fibrillation causes 1.5 to 2-fold increased risk of death, 2.4-fold increase of risk of stroke, 1.5-fold increased risk of dementia, 1.5-fold risk of MI, 2-fold risk of sudden cardiac death, 5-fold risk of heart failure, 1.6-fold risk of CKD, 1.3-fold risk of PAD. Therefore, prevention, detection, elimination, and treatment is necessary to prevent all these health conditions. And projection is that as the age advances, as I said, the burden of atrial fibrillation on population is going to increase, and most of this burden is going to be borne by low and middle income countries. We know that atrial fibrillation is an irregular rhythm, which is defined as a supraventricular tachyarrhythmia characterized by an irregular rhythm secondary to fibrillating atria with an atrial rate of 300 to 600 beats per minute, which is followed by erratic but rapid ventricular response with the rate of 100 to 108 beats, 80 beats per minute. Fortunately so, because most of the fibrillating waves are blocked at the level of natural barrier created by AV node. Otherwise, if all these fibrillating waves would pass to the ventricle, then one would drop dead. And which happens in case of WBW syndrome, where there is a bypass tract to carry extra fibrillating waves to the ventricle. Therefore, it becomes life-threatening in that situation. In ECG, what you will see? You will see an irregular RR interval, variable RR intervals, without any discernible P waves, which P waves will be sometimes replaced by fibrillatory waves, which may manifest as fine or coarse fibrillatory waves. Clinically, you will see variable heart sounds, especially the first heart sound will be variable in intensity, and you will see irregular pulse with variable pulse volume because of the differential recruitment of the cardiac myocytes. In the past, atrial fibrillation has been classified as per its temporal profile, according to which atrial fibrillation is classified as paroxysmal if it lasts less than 7 days with variable frequency of recurrence, persistent if it lasts for more than 7 days but less than 1 year, long-standing if it lasts for more than 12 months, and permanent. Permanent is a kind of long-standing atrial fibrillation where both physicians and the patient has made a combined decision that we are going to live with atrial fibrillation. We are not going to make any further attempt to convert the rhythm to sinus rhythm because of the various reasons, either drug toxicity or elderly patient or non-availability or financial, whatever reason. So physiologically, pathophysiologically, it is same as long-standing atrial fibrillation, but just that we have made a decision that we are going to live with this condition. So we call it permanent atrial fibrillation, nothing different than long-standing atrial fibrillation. Terms like non-valvular atrial fibrillation, chronic atrial fibrillation, lone atrial fibrillation, which used to be used in the past, are discouraged to be used because they create confusion. In latest guidelines, two more stages have been added to the classification of atrial fibrillation because the strong emphasis is given to prevention, because atrial fibrillation is easy to prevent, difficult to manage. So two more stages are added. One is at risk for atrial fibrillation, where you have risk factors, but there is no documented atrial fibrillation. This is similar to classification of heart failure, where heart failure is classified as A, B, C, D. A is at risk, B is asymptomatic structural heart disease, C is clinical heart failure, D is decompensated heart failure. Similarly, in atrial fibrillation, there is at risk, pre-atrial fibrillation, and permanent atrial fibrillation. At risk is various risk factors are present. Pre-atrial fibrillation, some features in the imaging like atrial enlargement, or in the ECG like atrial ectopic or short bursts of atrial tachycardia, which tells us that this patient has higher risk of developing atrial fibrillation in the future. So these patients are screened for and monitored, and their risk factor is controlled to prevent development of atrial fibrillation. Clinical atrial fibrillation, the classification remains same. Only thing is that one addition is that successful AF ablation patients which carry the risk of future recurrence. Now, as I was saying, strong emphasis has been given to risk factor modification, lifestyle modification, and prevention in current guidelines. So understanding their risk factors is imperative. The risk factors are classified into different categories. The risk factors may come from the demographic and anthropometric profiles like advanced age. As I said, age is, atrial fibrillation is a disease of aging. So advancing age is the most significant risk factor and non-modifiable, unfortunately, risk factor for atrial fibrillation. In addition, if you add other modifiable risk factors, the risk of atrial fibrillation increases. Smoking, obesity, hypertension, diabetes, all these conventional risk factors for any cardiovascular disease also apply to atrial fibrillation. Now, regarding several disease conditions like cardiovascular diseases like valvular heart disease, heart failure, coronary artery disease, cardiac surgery, structural heart disease, because of different effects on the atrium, they increase the risk of atrial fibrillation. So also different non-cardiac conditions like CKD, obstructive sleep apnea, obesity, and OSA specifically are gaining more importance and recognition as a risk factor for atrial fibrillation, because this is rising. There is concern for obesity pandemic, and this is coming to one of the top 3 or 4 risk factors for atrial fibrillation. So strong emphasis and management of obesity in OSA have been given to in current guidelines. So other conditions like metabolic disturbance, pulmonary disease, and post-operative state, all these increase the risk of atrial fibrillation. Some biological markers like ECG markers, if you see LVH, that is a risk factor. Biomarkers like elevation of pro-BNP, interleukin 6, TNF alpha, and lipoprotein little a, these are also considered as risk factors for atrial fibrillation. Genetic predisposition, of course, because of family history and heritability, they have underlying risk factor. And some of the socioeconomic determinants like education level, income level, and socioeconomic status, as shown in the previous slide, they will carry more burden of atrial fibrillation. Management of atrial fibrillation requires a thorough understanding of its pathophysiology, because most of the therapeutic insights remain hidden inside the pathophysiology of atrial fibrillation. The pathophysiology of atrial fibrillation is complex. There is complex interplay of various factors. But if I want to simplify, I will describe as such. Atrial fibrillation is characterized by two important pathophysiological hallmarks. One is having a trigger, and second is having an substrate. Let me explain. Trigger is the source of genesis of ectopic atrial impulse, and substrate is the atrial cardiomyopathy, which takes this trigger and fragments into atrial fibrillation. As simple as that. And what brings about this atrial cardiomyopathy? Various disease states by means of upstream elements. We call them upstream elements like oxidative stress, free radical mediated damage, inflammation, pressure and volume overload of the atrium, mechanical stretch and strain. All this lead to stretch and strain and cardiomyopathy, which I will describe. Now, talking about the trigger, the most important source of the trigger that has been identified, they are pulmonary vein ostia. The pulmonary veins, when they connect to the left atrium, the last part, that junction, there is little dilatation, as you can see here. This is called antrum. So this antrum and ostial part of the pulmonary vein, where the atrial myocyte is inserting, we call this atrial myocyte insertion into the pulmonary vein. These fibers, because of their different orientation and different electrical property, they act as a source of trigger. Now, discovery of this triggers, discovery of this anatomy acting as a trigger was a watershed moment in the management of atrial fibrillation. This was discovered by Haseguer et al. In 1990s, and this led to successful ablation of these trigger points, leading to successful conversion of atrial fibrillation to sinus rhythm. Now, second component is atrial cardiomyopathy, which is characterized electrically, and it is aptly described in the textbook Brownwald that it is characterized by inhomogeneous refractoriness, disparate conduction velocity, and atrial myocyte disarray. Let me explain what it means. Basically, what it means is there is heterogeneity. In the normal atrial cardiomyocyte, although it lacks a normal bundle branch like ventricle, normal conduction pathway like bundle branches in the ventricle, but they still have ill-defined conduction pathway called Bachmann bundle. They transmit the atrial impulse smoothly from one point of atrium to another point, because all the atrial myocyte act as a homogeneous tissue. But in case of atrial fibrillation patients, this homogeneity is lost and it is replaced by heterogeneity because of loss of atrial myocytes, alteration of the atrial myocytes, deposition of fibrous tissues, apoptosis, and also the atrial myocytes in the myocardium. The myocytes, although they are different structures, they are connected to each other and they talk to each other through what is called as gap junction, which is mediated by connection proteins. Now, this gap junction make this atrial myocyte as a homogeneous structure. Now, in atrial fibrillation patients, because of the disease states, these gap junction are reduced. They lead to conduction block. Water, electricity, and in intervention, we say wire. They always find a path of least resistance. So when impulse is transmitting or transiting through the atrial myocyte, they find a path of block. They will not go in that direction. They will find another path where it can transmit. So this smooth transmission is converted into vortices or eddy currents, as you can see here. And these eddy currents in chaotic and haphazard manner travel in different directions, meeting with each other, annihilating, creating further, and all this chaotic electrical phenomenon is created, which is called atrial fibrillation. At the macro level, at the anatomical level, what happens? The atrium, instead of smooth contraction and relaxation, it is replaced with fibrillation or quivering. So atrium, instead of smooth contraction and relaxation, it quivers. What it leads to is three. One is atrium loses its booster pump function, which is it fails to add to the ventricular filling. So ventricular filling is compromised. There will be low output state. Second, there will be stasis of the blood. So, in Wernicke's triad, stasis, endothelial dysfunction, and inflammation. These three leads to thrombogenesis. So, two of the Wernicke's triad is satisfied here. One is endothelial dysfunction. Second is stasis, leads to thrombus formation, so thromboembolism. Third is tachycardiomyopathy and loss of AV synchrony, which is very important. We often forget. Loss of AV synchrony tachycardiomyopathy leads to LV dysfunction. So these, in a nutshell, summarizes the pathophysiological principles behind atrial fibrillation. That is what we intend to treat. So, as I have mentioned, these are all pathophysiological mechanisms mediated by inflammation, infiltration, neural mechanisms, and underlying genetic principles. Various pathophysiological conditions act through these principles in different combinations, leading to atrial fibrillation. Finally, we see there is electrical remodeling, structural remodeling, and autonomic remodeling, which can be reversed by treatment of atrial fibrillation. One more thing to remember is atrial fibrillation begets atrial fibrillation, because when there is atrial fibrillation, the tachycardia itself is self-perpetuating. At one point, it will become independent of the trigger that initiated the atrial fibrillation. So, in chronic atrial fibrillation, in chronic stage, when you ablate the trigger also, the success rate will decline. Therefore, it is advised to act early. Now, coming to the management of atrial fibrillation, conventionally, the pillars of atrial fibrillation management of atrial fibrillation has rested on three pillars. One is rate control, rhythm control, and prevention of thromboembolism. Of late, in recent guidelines, a fourth pillar has been added, that is lifestyle modification and risk factor management, and that has been given the strongest emphasis upon, because as I said, prevention of atrial fibrillation is easy, but managing is difficult. Now, management of atrial fibrillation is no more individual clinician-driven management. It is a multidisciplinary approach involving all specialties, because one is multiple risk factors are involved. Two, the atrial fibrillation leads to multiple complications where it will need a coordinated approach by different healthcare specialties. Therefore, integrated management team is necessary for management of atrial fibrillation. As I said, prevention is the key to management of atrial fibrillation. Strongest emphasis has been given. So, primary or secondary prevention is necessary. Primary prevention prevents the development of atrial fibrillation. Secondary prevention, which I will talk later, is going to, one, decrease the recurrence of atrial fibrillation and also increases the efficiency of treatment. So, controlling hypertension, obesity, physical activity, all these are important. There was one study published in JACC 2015 called Legacy Study, which was designed to show the result of weight reduction in management of atrial fibrillation. Because obesity, by virtue of its specific pathophysiology, infiltration and loss of gap junction, and also by virtue of creating obstructive sleep apnea and triggering various pathophysiological state, leads to atrial fibrillation. Therefore, weight reduction has a significant impact in AF-free survival. So, in that Legacy study, it was shown that if you reduce the weight by 10%, the AF-free, drug-free, and ablation-free survival was significantly better compared to modest or no weight loss. Same was also seen in total AF-free survival. So, all this, just to emphasize the importance of risk factor management. So, current guidelines strongly emphasize risk factor management, that is loss of weight by 10%, moderate to vigorous exercise, target of 210 minutes per week, smoking cessation, and screening for OSA. Also, it is important to emphasize the abstinence from alcohol. By some reason, caffeine abstinence has not been shown to prevent atrial fibrillation episodes, although it reduces the symptoms in patients who report caffeine triggers. Same applies to optimal blood pressure control. Now, another study was published which showed that if you abstain from alcohol, your atrial fibrillation recurrence will be lesser compared to who do not abstain. And median percentage of time in atrial fibrillation during 6-month follow-up was 0.5% in abstinence group and 1.2% in the control group. Now, when you have a patient of atrial fibrillation, first decision you have to make is to apply a rate control strategy or a rhythm control strategy. At the outset, I want to make it clear that these two strategies, although they are competing in nature, but they are not mutually exclusive. They apply in different stages. There can be evolution from one approach to different approach depending upon availability. But broadly, because of different regions, some strategy is useful in one category of patients, other is useful in other category of patients. And also, many of those conclusions that rate control is equal to rate control, rhythm control, was drawn in the era of anti-arrhythmic medication in the rhythm control strategies. At that, the catheter ablation was in its infancy. So, keeping that in mind, a rate control is suitable for patients where rhythm control is not feasible. In any patient, rhythm control should be the ideal choice because of simple reason that it restores the AV synchrony, which is desirable. AV synchrony maintains the LV function, therefore AV synchrony is desirable. So rhythm control is always desirable in a given patient. However, in certain patients, elderly, patients having multiple risk factors, patients having multiple comorbids, patients with borderline hemodynamics, patients with liver dysfunction, raised creatinine, elderly patient, very frail patient, their rhythm control will lead to significant drug toxicity. Therefore, these are the patients where pragmatic choice is the rate control. And we have seen from previous trials like A-Fib, RACE and AFCHF that rate control, even a lenient rate control, is good enough for them, these kind of people. So rate control, even if it is a lenient rate control of 100 to 110 beats per minute, is non-inferior to rhythm control strategy in the patients I have described. What they do is they reduce the symptoms, improve quality of life, reduce heart failure symptoms, reduce tachycardia-induced cardiomyopathy, reduce inappropriate shock, enhance the biventricular pacing if the patient has cardiac resynchronization, and of course, reduce hospitalization. So they are a not ideal, but pragmatic choice in many patients. The agents which are used for rate control strategy are first line are beta blockers and non-dihydropyridine calcium channel blockers like verapamil and diltiazem. Second line is digoxin. Last is amiodarone in the rate control, because amiodarone has both rate control and rhythm control property. In the rate control strategy, amiodarone is the last. And IV magnesium used as a supportive treatment. These are the various drugs with their doses. You can see here, there are several beta blockers. Now, what is the approach? In a patient who presents with atrial fibrillation, who is hemodynamically unstable, first thing you do is life-saving, that is electrical cardioversion. The rest of the patients, if the patient is not in decompensated heart failure, beta blocker and calcium channel blocker are drug of first choice. Digoxin, although it is a very useful rate controlling agent, but the problem with digoxin is it has narrow therapeutic window, that is 0.5 to maximum up to 0.8 or 1 nanogram is the therapeutic window, beyond which the toxicity exponentially increases. Therefore, digoxin is reserved as a second line in many situations, almost all situations. Amiodarone is the last resort. And if the patient has decompensated heart failure, you have no other choice other than amiodarone. Now, long-term rate control, depending upon LV dysfunction or no LV dysfunction, you maintain with beta blocker or calcium channel blocker. One thing to remember is that in LV dysfunction, you cannot give calcium channel blocker. Beta blocker is applicable to most, and digoxin as a broad spectrum applicable to most of the situations, except for various contraindications and except for the fact that it has narrow therapeutic index. If you have started with one drug, first line agent, then if you are successful, you continue with that. If not, you have a choice to add a second agent. So beta blocker is combined with calcium channel blocker. Digoxin is combined with calcium channel or beta blocker. If still you need to reduce the rate and you don't have other choice, you can add a third line agent, which is very, very rare. If you add all these three, the chance of complete heart block is significantly high. So maximally we try to control with escalating doses of single agent. If we are not able to control, then we usually add a second agent. Last resort is AV nodal ablation and pacemaker implantation. So this is used as a last resort, because if any patient, we cannot maintain the heart rate in certain level less than 110, then in that situation we recommend to ablate the AV node completely, block the transmission of the fibrillatory waves to the ventricle completely, and of course you have to replace with pacemaker implantation. Pacemaker implantation again has its own problem in patients who have LV dysfunction, but with the current advent of conduction system pacing, that problem is also solved. Now coming to rhythm control, as I said, rhythm control is desirable in most of the patients. That should be given first chance, at least for some time you try with rhythm control, because we have seen in many of our patients practically, when patients reverse to sinus rhythm from the atrial fibrillation, their LV function dramatically improves. So those of us who have managed atrial fibrillation with rhythm control, we know that the dramatic improvement of LV function when they revert to sinus rhythm. So rhythm control should be given a go at the outset, at least, if not as a chronic therapy in most of the patients, and wherever is it feasible. Now, with the advent of catheter ablation, as proven in the trials like CASTLE-F and Cabana trials, rhythm control has taken a front row now. Now, rhythm control can be achieved is recommended in this patient situations. Recent atrial fibrillation, where chance of reverting to sinus rhythm is high, patients with persistent AF, reduced LV function, patient with heart failure, younger patients who can tolerate the drugs, these are the ideal candidates for rhythm control strategy. The rhythm control can be achieved by three. One is electrical cardioversion, two is pharmacological cardioversion, and third is catheter ablation. Let us talk about electrical cardioversion a little bit of, because it is not talked about much. If the patient presents hemodynamically unstable, then the immediate therapy is immediate electrical cardioversion as a life-saving measure. So in this, what you do is you give a maximal shock that is available in the device, mostly in a biphasic device, 200 joules is the maximum. So you give that, start with that. Electrical cardioversion efficacy may be improved by giving a pre-treatment of a antiarrhythmic drug. Now, if you are opting for an elective electric cardioversion, not an emergency, elective electrical cardioversion, in that situation, the chance of thromboembolism is high, because when the atrial fibrillation converts to sinus rhythm, there is atrial stunning. So atrial function, there is atrial dysfunction, even though it has come back to sinus rhythm. So there is chance of thrombus formation. Now that atrial starts to contract and relax normally, it will start throwing up the thrombus. Therefore, it is imperative that you make sure that there is no thrombus present in the left atrium. So what is the strategy? Let me stepwise go as per the temporal sequence. Now, if the patient has presented with atrial fibrillation and he is fully anticoagulated, by fully anticoagulated, I mean if he is on warfarin, the INR is 2 to 3. If he is on NOAC, you know that standard doses of NOAC, although there is no monitoring in that, but if patient is receiving the standard dose of NOAC, in that situation, you can go ahead and do electrical cardioversion. But if the patient is not anticoagulated, in that situation, if the patient has presented early, the definition of early in the earlier guidelines were 48 hours. Now it has been changed to 12 hours. Now the patient has presented within 12 hours, you can still go ahead with electrical cardioversion. Between 12 to 48 hours is the gray zone, where if the patient has low thrombotic risk, charged to score of less than equal to 1 or less than equal to in male and less than equal to 2 in females. In that situation, or patient has no previous thromboembolic episodes, in that situation also you can go ahead with electrical cardioversion. Patient presenting with atrial fibrillation in 12 to 48 hours with higher thrombotic profile, you have to make sure he receives full anticoagulation like other patients, like late presenting patients. So in that situation, and also patients who present more than 48 hours, you make sure that he has no thrombus, make sure he's fully anticoagulated for at least 3 weeks, after which you can go ahead for electrical cardioversion. Another strategy is alternative to this is doing a transesophageal echo and ruling out the left atrial appendage thrombus or left atrial appendage Shaikh or left atrial appendage velocity of less than 40. If these are ruled out, then also you can go ahead with electrical cardioversion, with a caveat that you understand the limitation of transesophageal echo in documenting the thrombus, because it's a three-dimensional and complex structure. That is, I'm talking about left atrial appendage, and there is chance of thrombus being hidden in the crevices, which can be missed by toe, and it can do a shower of embolization. So with that caveat, if you understand and patient has understood the risk, you can go ahead with electrical cardioversion. Now, and apart from electrical cardioversion, next approach is pharmacological cardioversion. And regarding pharmacological cardioversion, what I want to say is the most of the anti-arrhythmic drugs, apart from amiodarone, they require one prerequisite, that it should be normal LV function, no structural heart disease, no previous LVH or anything, or no previous MI. In that situation, only most of the anti-arrhythmic drugs can be prescribed. In other situations, amiodarone or its congener dronedarone are prescribed. Dronedarone is contraindicated in current or previous heart failure patients. With that caveat, if you understand the anti-arrhythmic drugs, you can prescribe anti-arrhythmic drugs for pharmacological cardioversion. In normal LV function without prior MI and structural heart disease, drugs like dofetilide, flecainide, and propafenone, and dofetilide's congener, ibutylide is available now, which is given in emergency ER situations. I think 1 mg over 10 minutes, followed by another half an hour by 1 mg 10 minutes is the dose that is nowadays practice. Apart from that, flecainide and propafenone are useful agents also given in the rhythm control, anti-arrhythmic drugs for rhythm control strategy. Flecainide and propafenone can be given in the pill in the pocket strategy, provided the efficacy of these drugs in that particular patient has been proven earlier in a hospitalized setup. And last, amiodarone is useful for wide spectrum of patients. It doesn't have as much pro-arrhythmic potentials of other drugs. Therefore, it is widely prescribed. Now, alternative to all this is catheter ablation, which is applicable to many situations and which is emerging as the number one strategy for atrial fibrillation. One, it avoids pro-arrhythmic complications of anti-arrhythmic drugs, and it has higher success rate compared to any other drugs. One word about the strategy of these anti-arrhythmic drugs is dofetilide and sotalol. It is recommended to keep the patients in hospital for at least 3 days because of their pro-arrhythmic potential, especially dofetilide, because of tendency to prolong QT and causing tau status D points. So chance of ventricular fibrillation is high in these patients in the early part of the administration. So you need to keep them with continuous ECG monitoring, see their renal function, rule out hypokalemia, hypomagnesemia, or treat them if they are present, and keep your defibrillator ready always. And sotalol has similar recommendation. Flecainide and propafenone, which can be given as pill in the pocket strategy, but first dose should be given in the facility. And if they are successful in converting the atrial fibrillation to sinus rhythm, you can give them as pill in the pocket strategy, wherein you ask the patient to carry flecainide and propafenone, one of them, of course, tablets in their pockets, and whenever they get atrial fibrillation, and this is useful in paroxysmal atrial fibrillation, where the patient have infrequent episodes, so they can carry that, and whenever they have atrial fibrillation, ask them to pop a pill, and that will restore to sinus rhythm. Now, this is the emerging as the therapy of choice in rhythm control strategy, that is catheter ablation, which is applicable in various situations, whether it is paroxysmal or persistent, with or without recurrence, and in heart failure situations. Now, as I have discussed, the targets for catheter ablation is pulmonary vein ostia. So, pulmonary vein isolation, or we call it PVI, is the primary mode of therapy in case of catheter ablation. There may be other ablations you can do as a secondary, but primary mode is pulmonary vein isolation, wherein you give ablation currents at the junction of the slightly away at the junction of the pulmonary vein ostia, which will block the transmission of the triggers transmitting to the left atrium. Thereby, they tend to convert the atrial fibrillation to sinus rhythm with a success rate of above 80%. Electroanatomical mapping is required for proper identification. In earlier era, single electrodes were available, where you have to patiently pick one burns at a time. But with the advent of ring electrode, multiple burns can be given at one go, which improves the efficacy and saves time. Various complications can arise. Of course, pulmonary vein stenosis, cardiac tamponade, thromboembolism, phrenic nerve injury, esophageal damage because of their proximity. With the advent of modern technology like pulse field ablation and cryoablation, the safety and efficacy profile have significantly improved. Only thing is that with cryoablation, the efficacy rate is slightly low. Various risk factors, if they are present and uncontrolled, they will reduce their efficacy. Therefore, treatment of them improves the efficacy of catheter ablation. If the patient received catheter ablation, it is advisable to give anticoagulation for 2 to 3 months at least. And if the patient has a high Charles-Bach score, then chronic anticoagulation is advised. Now, this is the one of the pillars of management of atrial fibrillation, that is prevention of thromboembolism. Atrial fibrillation patients, by virtue of the pathophysiological hallmarks and by virtue of the stasis that I discussed, they develop tendency to develop thrombus. And higher the Charles-Bach risk, higher is the tendency to develop thrombus. Therefore, their thrombotic potential should be assessed by various scoring systems are available. Commonly used is Charles-Bach risk score. A patient in the high-risk Charles-Bach score, that is more than equal to 2 in men and more than equal to 3 in women, they carry about more than equal to 2% risk of thromboembolism. Therefore, they need to be anticoagulated chronically. Ideal choice is novel coagulants because they have better safety and efficacy profile. Alternatively, you can give warfarins. Warfarin in certain other situations, I will discuss later. In low risk category, there is no need to give thromboembolism at that point of time. However, you need to understand that Charles-Bach scoring and thrombotic potential scoring is not a one-time exercise. You need to continuously monitor these patients annually to see that they accumulate some risk on the way, and they may transition from low risk to intermediate or high risk later in their life, requiring anticoagulation later. So a patient is low risk doesn't mean lifelong they are free, they will remain free of anticoagulation. You need to monitor. Now, major controversy or gray area is intermediate risk patients, where current guidelines say that it is reasonable to give anticoagulation in these patients, particularly men more than 1 and female more than men equal to 1 and female Charles-Bach score equal to 2. They need to be anticoagulated as well, provided they have low bleeding risk. Now, as regards bleeding risk, these patients also need to be assessed in terms of bleeding tendency. There are various risk scoring system available. Most commonly used is HAS-BLED. Maximum score is 9, more than equal to 3 is high risk for bleeding. But one word I want to say is that a patient who has high risk of bleeding is not a lifetime contraindication for anticoagulation. You need to assess their bleeding risk periodically, and you can also do some intervention to reduce their bleeding. For example, the patient may have temporary high risk features. For example, has a surgery done or a bleeder in the form of hemorrhoids, which can be treated and which can be his bleeding risk can be reduced. Or patient is on certain drugs, antiplatelets, which can be stopped later, or patient is on NSAIDs, which can be stopped later. Patient is taking alcohol, you ask him to abstain. So his risk can be modified and you convert him into anticoagulation group. So high risk bleeding doesn't mean patient is always contraindicated for anticoagulation. You make sure that patient receives anticoagulation by any means. This is called beyond charts VAS scoring. There are patients who, irrespective of their charts VAS score, still carry high thrombotic risk by virtue of several other conditions. For example, chronic kidney disease, mitral stenosis, left atrial enlargement, biomarker elevation. These patients, these factors need also to be factored in while deciding for anticoagulation. For example, as I discussed earlier, some patients, even though they fall into the low risk category by charts VAS, by virtue of having mitral stenosis, they have high risk of thromboembolism. Therefore, they also need anticoagulation. One more thing I want to add, which is not mentioned here, is that HCM. In HCM patients, if they develop atrial fibrillation, irrespective of their charts VAS score, you need to give them anticoagulation because they carry high risk of thromboembolism. Now, patients with valvular heart disease have a separate guidelines regarding anticoagulation indication or recommendation. Patients who have moderate to severe mitral stenosis and mechanical heart valve, they receive warfarin as an anticoagulation of choice. Other native valve disease, you can give either depending upon their charts VAS score, but NOAC is more preferable. Patient who have bioprosthetic valve less than 3 months, you treat them as mitral stenosis and mechanical valve and give anticoagulation accordingly. Patients who have crossed more than 3 months, NOAC is indicated only if there is high charts VAS score. So this is the recommendation. Now, this is the final approach to anticoagulation free management of this thing. Thromboembolic phenomenon, that is percutaneous left atrial appendage closure. Many of the patients, you will see that they need, they have high risk of thromboembolism. You will see that by virtue of those risk factors, they have high risk of bleeding as well, because bleeding risk and thromboembolic risk, many of the risks overlap. So in those patients, elderly patients, you cannot give anticoagulation, or you have given anticoagulation, patient has bled, developed intracranial hemorrhage, they are suitable candidates for anticoagulation-free approach to management of thromboembolism. Most commonly done procedure is percutaneous left atrial appendage closure, which is given both in anticoagulation contraindicated patients and anticoagulation eligible patients, but still as a patient preference, as a physician preference, left atrial appendage closure can be done. So the idea is that block the source of development of thrombus. So atrial appendage being a sac that has a tendency to develop thrombus, and during atrial fibrillation, it develops showers of thromboembolism. Therefore, blocking the exit of thrombus is the approach in this approach. Watchman device is the pioneered ring device, which heralded the era of percutaneous left atrial appendage closure. The trial was Protect AF, after which it received FDA clearance. After that, many devices came to the market, like Amulet and its predecessor, Ampliger cardiac plug. A few years back, I had an opportunity to implant this device in India. Basically, this is an ACP, ambulatory cardiac plug. Basically, we go from the transvenous access, do the transeptal puncture posteriorly and inferiorly, which faces the left atrial appendage mouth, and we engage the left atrial appendage and take a pictal catheter injection and measure the size of the appendage. Appendage size both angiographically and the transesophageal echo, and we size the device. We upsize 20% upsize from the size we measure and implant the device in a standard unsheathing technique, after which sealing is confirmed by angiography and transesophageal echo. And procedurally, we give anticoagulation, Watchman device. The recommendation is to give anticoagulation along with aspirin initially, after which, after 45 days, anticoagulation is stopped and you continue with aspirin and clopidogrel. Clopidogrel is again for stopped after 6 months and you continue with aspirin. But in case of ACP and amyloid, only dual antiplatelet is recommended. So it is given for 1 to 6 months, after which either clopidogrel or aspirin is continued. Alternative is surgical excision and exclusion, which is done during the surgery. If a patient is going for surgery who has atrial fibrillation, high charge bus score, it is recommended to excise. But it is not proven that they will remain anticoagulation free. So that is the my presentation. In conclusion, atrial fibrillation is the commonest clinically significant sustained arrhythmia with a lifetime risk of 20 to 30% associated with significant complications. Its therapeutic decisions are complex, so preventive measures should be employed, which is simple and effective. The therapeutic approaches include rate control, rhythm control, and stroke prevention. Recurrences are very common, and you have to manage the comorbidities as well. Newer treatment modalities like catheter ablation and left atrial appendage occlusion have increased the therapeutic horizons to improve the quality of life of the patient with atrial fibrillation. Thank you.